Welcome everyone to today's session. We are having a question and answer session for the first time on the South Sudanese Women Intellectuals Forum. We are thankful that you're joining us today. I would like to thank everyone who is supporting the forum and by watching and also by appearing on our sessions. Today's session will be a first of its kind, and we'll be taking questions live from the audience. And these questions will focus on child health and women's health issues. My name is Dr. Anne Lomole, and I am a pediatrician and an infectious disease consultant. And I will be focusing mostly on the child health aspect. So please send your questions. And I am joined today by Dr. Idioro Joseph, who is an obstetrician and gynecologist. In fact, she was the first South Sudanese obstetrician and gynecologist, and as of recent, is now a gynecological oncologist, one of the first gynecological oncologists in South Sudan. So it's great to have her here. She has many years of experience in the field of women's health, and we are privileged to have her on this panel. So we'll be taking questions from the audience, and please remember that questions should focus mostly on patient education. We don't want to get too technical so that people can understand what we're talking about. And we want us to focus mostly on child and women's health. So please send us questions related to that. I would like to thank all those who have supported the South Sudanese Women Intellectuals Forum since its inception, members, the audience, and our various partners, both local and international, including the UN Women. We are grateful for the opportunity to continue impacting our country and our communities on this platform. And I think I can speak for both Dr. Idioro and myself. We are also grateful that we're able to share information on health on this platform. I would also like to thank Aisha, who's currently on technical support. And we will go ahead and start. And I would encourage our audience to send in their questions. As we are currently streaming live on Facebook and YouTube, please feel free to send your questions on our Facebook page and to share this session on all your social media platforms because I feel that we're going to learn a lot today, and we will try to answer as many of the questions that are forwarded as possible within the time allocated. We are looking at about an hour, maybe an hour. And for those questions that we're unable to answer in this session, we will set aside some time to maybe contact you directly or question or answer the questions on our platform. And for the things that will need a more in-depth discussion, then we can plan for a different session where we can have a panel that is able to discuss those specific topics and concerns. So I want to thank you once again for joining us, and thank you, Dr. Idioro. It's an honor to have you here, our first gynecological oncologist from South Sudan, and we are so amazed. You know, it's inspiring actually to have you having achieved that new qualification, and we are so very proud of you. And I'd like you to maybe just introduce yourself in brief to the audience and tell us a little bit more about yourself and your journey in obstetrics and gynecology.
Thank you, Anne, for this amazing introduction. My name is Dr. Idioro Juko. I'm an obstetrician gynecologist by profession. And as Anne has said, I've just completed my fellowship in gynecological oncologist. So I now have a new title of gynecological oncologist. So thank you so much, Anne, for this introduction once again. Yeah, I've been practicing as an obstetrician gynecologist for now, this is the 8th year. Yes, for the last 8 years. But the journey started long back in South Sudan, where I was working in Eastern Equatoria. And I saw how women were coming late for delivery with obstructed labor. And that actually really inspired me to do obstetrics. Yeah, thank you.
Thank you so much for that, Dr. Idioro. And it's very clear that our country has a lot of issues, especially when it comes to taking care of women's health and health in general, because of the state of our health facilities and the state of our human resources, in view of the fact that we were in conflict for quite a long time, and even post-independence, the conflict continued. And it's understandable that it will take a while for our health services to actually improve to a state where we are able to prevent further maternal death, especially due to labor that was not well managed. And I'd like to ask you another question about some of the challenges that you may have experienced, especially when you are practicing in South Sudan. What are some of these challenges that you experienced in, in your practice, especially in South Sudan? Like what stands out for you that you think needs to be looked into in brief?
Yeah. First, when I start talking about the challenges when I was working in Eastern Equatoria at that time, but I think by now there is some sort of improvement. The first challenge was about theater. We didn't have a well-equipped theater. And I think this is a challenge which is still ongoing in most parts of South Sudan. Because we only have 2 ways for delivery of a baby, and people should not stop delivering because there is no facility. And there is no way I can say this mother from conception to delivery is going to be normal. We actually call normal delivery after it has already happened. So when you're coming during antenatal clinic, you have to know that your chances are 50-50 normal or surgical delivery, which is a cesarean section. So actually, wherever we conduct delivery in all parts of South Sudan, we should have a theater in place. And this was one of the challenges that we faced in Eastern Equatoria, in Torit Civil Hospital at that time. But at least they had the theater, the room that was called theater with the theater table. So we had to do, now we became both the surgeons and the anesthetists because we didn't have an anesthetist. Even the anesthesia assistant who was there all through has never done surgery like in almost more than 10 years. So he couldn't even know what to give. So we were the ones who were actually giving the anesthesia. And what anesthesia can you imagine we were giving? We were using local anesthesia. We give for the skin. You start cesarean section when the mother is still awake. You put local anesthesia on the skin. Then when you reach deeper, where it's called the rectus, and then that is when actually somebody feels pain. And that is when now we give them diazepam and ketamine. And you know, these are all dangerous drugs, especially ketamine is not supposed to be given where there is no oxygen or there is no possibility of you intubating the patient. But we used to risk that and give ketamine and diazepam so that we complete the cesarean section. And what I can say that South Sudanese women are very resilient because from all the cesarean section or appendectomy that we did during that time, none of them got sepsis. And the place, when you see that theater, is not even clean. We don't know when to sterilize it and when is it even sterilized the last time. And secondly, you might start a procedure and then it gets dark. You know what we use? We can use torches when you are stitching. So there was basically no light. So these are the challenges that I had during that time. But then after that, I came to Juba. I practiced in Juba Teaching Hospital because before coming for my master's in Obstetrics and Gynecology. Now in Juba, the main challenges was again electricity. That is when it gets to night. But during the day, most of the time you get anesthesis and you get things done. Yeah, so in Juba, even sometimes we used to reach a point whereby the relatives get for us the fuel for the generator so that their kin can be operated. So we had so many challenges during that time, but I learned now Juba Teaching Hospital has improved in terms of the theater facility. Yeah.
Wow, I think I can testify to that because for some time before I got into pediatrics, which is my main specialization, I worked in Yei Hospital, and yes, we experienced similar challenges where anesthesia was an issue, and sometimes we couldn't get the anesthetist, where electricity was an issue, and we had to do both things. One, to give the anesthesia, and the other have to do the surgery. And sometimes, yes, we would have to use the light of the phone. And that is a reality that's there in our country. and also the truth is in many areas of Africa. And we hope to be able to get to a point where we are able to ensure that we take care of our mothers the way we should, exactly the way the protocols dictate. Now, I'll go a little bit into a bit of pediatrics, and I'll talk a little bit about the importance of having a pediatrician in a delivery setting. The reason for this is that there's so many things that can happen in between the labor period and the delivery of the child that might put the child at risk. And it's important to have someone there who is able to identify some of these risk factors, especially for very high risk cases where the possibility of this child having issues with breathing, having issues with prematurity are there. So pediatricians have to be there so that they're able to assess the child and ensure that the child is breathing adequately, and if necessary, then do the necessary interventions and ensure that the child is kept warm and is able to breathe until you're able to transfer the child to a unit that maybe can take care of any intensive care that is needed for the child. So one of the questions that I'm being asked is about cerebral palsy and some of its risks. Cerebral palsy is basically where a child has something that occurred probably during, most of the times it's during pregnancy, then it affects the development of the brain of the child. So when the child is born, then they have issues related to either seizures, where they have convulsions, or they might have issues related to, sorry about that, they might have issues related to how they move their limbs, how they develop in terms of the IQ, how they develop in terms of motor development, and how they develop in terms of a speech. So it's basically a non-progressive form of injury to the brain that affects multiple systems. And some of the risk factors could be things that happened during the pregnancy. They could be infections, there could be issues with oxygenation to the child while the child was inside the womb, or even during delivery. And this can then affect the child after the child is born. So in terms of management, when it comes to cerebral palsy, it's what we call multidisciplinary management. So there are many people involved because, as I said before, it affects the brain, and therefore many other factors are involved in terms of what happens to the child. So you have issues with speech, which means that you will need someone who will take care of the speech therapy. You'll have issues with motor development. And by motor development, I mean when the child is able to walk, whether the child is able to do anything for themselves. So that requires them to go through what we call occupational therapy and physiotherapy to sort of help their limbs to be a bit more mobile, and if possible, if they're not too badly affected, to be able to do a few things for themselves. Of course, there are different spectrums. There are those who are minimally affected, there are those who are extremely affected. Then for some children, then they also have convulsions, which is basically seizures, and this can further cause deterioration of their brain status. So a neurologist, a doctor who is a specialist in things to do with the brain, has to be present in terms of management, and they have to take care of those seizures, and they also have to take care of the issues to do with the hands and the legs, and sometimes they have a lot of tightness, what we call increased tone, that needs intervention in terms of injections to release that tension so that they're able to move their limbs, and they require consistent follow-up by neurologists. Now, for some of them, feeding is also an issue. So they are unable to swallow properly. They have what we call reflux, where the food goes down, but then it comes up, and that can result in problems to do with recurrent pneumonias, some of them even ending up in ICU. And in fact, the truth is, most children who have cerebral palsy end up passing away because of these recurrent pneumonias that end them in intensive care. So sometimes some of them have to be put for tubes, what we call PEG tubes, that are put inside the stomach so that they bypass the mouth and the reflux doesn't happen. and then they are given the food through there. So it's a multidisciplinary kind of management. So if you have a child who has cerebral palsy, remember that most of the insults actually happen pre-delivery. That is something that has to be remembered, because I know quite a number of people feel, okay, the labor wasn't managed properly and all that. That can happen, but it's a very, very small percentage where that is the case. And thereafter, you have to ensure that this child is effectively, actively followed up by a multidisciplinary team that takes care of all the aspects of their basically their ability to survive, and to be taken care of in life. So depending on the spectrum, it depends on how severe the issues are, and the level of care can be really, really take a toll on the parents, especially. And sometimes you actually have to put the family or the caregiver into therapy, because it's very, very difficult to take care of a child who is absolutely dependent on you for everything. Of course, the prayer always is that our children, when they're born, they're completely fine, they develop the way they're supposed to, they're able to grow up into individuals who can take care of themselves. But unfortunately, because of factors that sometimes are not within our control, that might not happen. Okay. So I'll pose the next question to you, Dr. Idioro. There are many myths surrounding contraception use, and I know there are quite a number of women who are very, very jittery about using contraception, because people are, oh, it might cause infertility. If you take contraception, you will stay for like 4 or 5 years without children. For some of those that are put the what we call the intrauterine devices, people are afraid of infections and blockage of the tubes and infertility still. And some people are also afraid that there might be side effects from the contraceptives that might also lead to death. Some people have mentioned things like what we call pulmonary embolism and all that. So could you please, like, sort of in just very simple terms, demystify these issues with contraception, and tell us what should a woman look into when they're thinking about what kind of contraceptive to use? Dr. Idioro.
Okay. Yeah. Thank you, Anne. Now contraception is, I think, like when a woman is looking into contraception, so they have to see a gynecologist first, because it involves a discussion with the woman itself. It is actually an individualized thing. We have to see you, your age, your weight, the risk factors you have, whether you are diabetic or hypertensive. These are all considerations that should be put in place for us to give you the right contraception that will suit your situation. Again, like if you have just delivered, you are still breastfeeding, there is also a specific contraception for use during that period. So contraceptives are not like just something you walk into the pharmacy, although they are there, and just buy. So if you do that, that is when you get a lot of these complications, and then all of them are being packed as complications from the contraceptives. But if the right contraceptive is used for the right person, most of these side effects we will not get. Like, for example, if you're above 35 years, or you are obese, or you have diabetes or hypertension, or you have history of clots, what we call DVT, we will really discourage you from taking the combined oral contraceptives pill. So because this one also increase the risk of getting a DVT, which is a thromboembolism. Yeah, so this one we will really discourage you. But people above 30, when you're below 35 and you have a slim body, you don't have any other risk factors, the combined oral contraceptives are good. The only thing that, because you take them every day on daily basis at the same time, so if you are a busy person, that is not something that will work for you. Another one, we have the IUCD, which are the intrauterine contraceptive devices. So we have different types. We have the copper T, we have the copper multilode. These ones, they are non-hormonal contraceptives. So actually, most of the time they are the best choices. And again, with the intrauterine devices, we have the Mirena, which has progesterone. It has less progesterone. And this one, at the same time, like for example, we can use it for someone who is having like early stage endometrial cancer, that like when we are managing an endometrial cancer, somebody who is still young and still want to give birth, it's actually at the same time part of treatment. So like if you're using the Mirena for someone above 35, 40 years there, so it's at the same time protective against endometrial cancer. Now, when we come to the myths that are associated with contraceptives, actually they don't prevent someone from getting pregnant, or they don't cause infertility. Now, when people say it, like the IUCD comes with infections, most of the infections which are associated with IUCD are actually the candidiasis, and candidiasis will never cause infertility. The problem is you might get infection when you have the IUCD, which we call the STIs, some of the chlamydial infections. These are the things which can cause tubal blockage. But then again, because if I have the IUCD and then I get my chlamydial infection, which is mild, and then it resolves, or I take some antibiotics and it resolves, nobody has tested that you had a chlamydia. All that you knew is that you had an IUCD, and now you have removed it, and you're not able to get pregnant. So you associate it with the IUCD when actually it was the chlamydial infection which has blocked your tubes. So, and now mostly when you use the contraception, most of the contraceptives, immediately you withdraw from contraceptives, majority of people get their menses back, and up to 70% get pregnant within the same month. Now, no, within the same year, up to 70% of the population would have achieved their fertility back. So contraceptives is totally disassociated with infertility unless any other causes are associated with them. Yeah. And you're muted. You are mute.
Sorry, I was on mute. Yes, thank you so much, Dr. Idioro, for that. It's important that we understand that those, especially what you told us about the issues related to infertility, because I think that's a fear that most of us women have generally, that our fertility might be affected by these contraceptives. But I think you have been able to tell us a bit about how that is actually not something that we should actually be so worried about. Now, the other question I'm seeing is about autism. And autism is something that many people don't really understand. And there have been a bit of myths about it, especially this specific one that some parents actually ask me about the relationship between autism and vaccines. And I'd just say autism is basically uh, something that affects some children where they're unable to socialize, with other people, with people, and with other children, and they're unable to communicate. So it's like a communication stroke socialization issue. And in terms of what causes it, there's not been a specific thing identified, but some of the theories suggest that your genetics might have something to play. You find that for some people, you might find one or two autistic children or an autistic parent. So there's a belief that there's some genetic association. Now, some of the theories have suggested some viral infections might come into play. Some medications that are used during pregnancies might have a possible contribution to the genesis of autism. So there's no specific thing that we can say causes autism, but there's a number of theories around why it happens. So children who have autism can be identified from about specifically from about 2 years of age and above, but sometimes you can actually see some of those symptoms a bit earlier. So what happens is that they are unable to actually, in terms of socialization, it's difficult for them. So speech development is a problem. They tend to have a repetition of speech. So they're repeating speech, but not because they understand the speech, but just repeating the words. They're unable to maintain eye contact. Most of them are unable to do imitative play. You know, the way children can pretend that I'm doing this and I'm doing that. And they tend to have a fixation to objects and not people, and can be very overly sensitive to certain stimuli like lights and noises. And they tend sometimes to be very aggressive in their interaction with other people. And this inappropriateness of social interaction has a lot to do with the way the brain has development. So it's developed. So they tend to not be able to socialize like other children. So this is something that over time can be worked on, and most of the time they have to go through what we call behavioral therapy, where they are taught how to behave in particular situations, and then they are also exposed to systems through which they can communicate. So there are certain things that we use as pediatricians where you actually use pictures for communication, and that they are taught over time. And it's important to adjust their environments, whether it's school or at home, to be able to make it easy for them to learn how to socialize and to learn how to interact with other people. And this then indicates the need for early intervention. When you're talking about autism, the intervention has to start when they're quite young, because at least at that time it's easier to mold development, because most of the brain development occurs during that time. Then they're taught also social skills, and they also have to have speech and language therapy so that they're able to now be able to speak, and even to the extent that they can be understood, instead of pointing at things or not, or just repeating words without understanding what the meaning is. So there are many things that they have to go through. So for most pediatric conditions, actually, as I said before, intervention is multidisciplinary. So you have to look at the home setup, you have to look at the school setup, you have to look at how they can integrate in the society, and not be in a situation where they are actually set aside and made to look like they're different from other people. And some people have also even suggested nutritional or therapy, where they're given foods that are gluten free. No specific identification has been made as to why that works. However, it has been shown to have some sort of positive effect. So what I want people to take from this is that there has been no research that has shown that there's a link between autism and vaccines. Genetic factors have been identified. Factors associated with viral infections and medications have been thought to have a part to play. And therefore, you should not be afraid to take your children for vaccination because of the risk of autism, because there's not been any link. In fact, whatever research actually brought that into play was actually pulled, because there was no evidence that there was actually a link. Okay, so I hope that sort of answers that question. So please keep your
Yes,
questions coming.
and let
Yes,
me just add something. I happened to interact with a neonatologist
yes,
who said mothers can actually observe children with autism as early as during like the first 3 months. You know, in the first, after 3 months, you are able to notice whether the baby is communicating with you or not, especially when you are breastfeeding, there should be that eye-to-eye contact with the baby. But she told me that most babies with autism at that early stage or early age, they actually don't have this contact. They are breastfeeding and their attention is somewhere else, not even with the mother. So is that true? Maybe you can elaborate on that.
It's very difficult to actually identify autism that early. Like the mother would have to be extremely keen. And the problem with the saying that is that you might create a situation where there's a lot of panic, in the sense that the mothers will be constantly looking at the children and wondering, okay, is this child really connecting with me or communicating with me? It's very difficult to say at that time unless you're extremely, extremely keen. So we try as much as possible not to give that diagnosis to children who are especially under 2, but you can actually see when they're a bit older and they're learning to interact with people, let's say above 1 year of age, and you can see this child, how they communicate, how they play, and that's when now it becomes more obvious. But when they're in the stage of months, it's really, really difficult. And it's, for me anyway, this is my personal opinion, not based on anything else. If now we get to a situation where we tell mothers to look at whether the baby is actually looking at them and everything, I think it will cause a situation, it will actually create panic. And, and it's important to give the child time to mature enough for you to be able to tell that there's a problem here with speech and there's a problem here with social interactions. For me, I'd say you would have to be very, very careful to start talking about autism at 3 months. That is my personal opinion. I don't know what the neurologists would say, the pediatric neurologists will say, but I think post this discussion we can ask them, or they can even send in their comments as we continue with the discussion. But thank you for that. It's something that people have said. It's not something I've not had before. Yes, I have had that before, but I would not want to put parents in that situation where they're busy looking for this eye contact when the child is 3 months of age. Yeah. Okay, thank you so much, Dr. Idioro, for that. Now, we talked a little bit about fertility issues and the myths around contraception and all that. What are some of the other things you've come across when it comes to fertility? And when someone is told that they have an issue with fertility, what are the things that come to mind, like commonly? And what are some of the things that are done to sort out these individuals who have issues with fertility?
Okay. Now, when it comes to fertility, actually, it involves 2 individuals. So the first visit, you have to talk to all of them, the couple together, and again, you talk with them, one person at a time, separately. Then you will basically get what is involved in that issues with fertility. Sometimes they're just very simple simple things, like people are not having regular sexual intercourse, which is actually one of the factors. We always say, for you to diagnose primary infertility, because fertility actually there are primary and secondary. Primary infertility is when you like the lady has never gotten pregnant before. Now, when we come to secondary infertility, that is when there was a pregnancy which happened, either it led to a miscarriage or whatever the outcome of that pregnancy. Then it took a bit of time for the same person who is now trying to conceive and not able to conceive, despite the fact that she's having regular sexual intercourse and is not on any contraceptives. That is when actually you diagnose fertility, and it has to be at least 1 year. So if somebody comes like at 6 months that I have been trying to conceive and I'm not able to conceive, then you give them still times and you advise them. Then again, you ask if there is any history of any sexually transmitted diseases, like I said earlier, chlamydia, which is actually common. So, and most of the time they go at notice, and people don't know. They just get a little discharge and they go to the chemist, get antibiotic, and that is it. They don't know that it has already blocked the tube, which is actually most of the commonest cause of infertility, of primary infertility or even secondary infertility. But for secondary infertility, it can be obvious. So like maybe after delivery, the person gets infection, which has led to blockage of the tube. So, but basically, we first check the tube if that person has regular cycles. So, if there is irregularity in the cycles, that is when we go to check the hormones. And again, for young people, most of the time it is a polycystic ovary disease. So, in the polycystic ovary disease, if the person says, "I've not even had any infection that I've known," uh, that I'm aware of, and then the husband even or the partner doesn't have any infection, STI. Although in men, most of the time when they get sexually transmitted infection, it's usually clinically presented, and they will always tell you, "I've been treated for this." But for women, most of the infections go unnoticed. That is where the problem is. Most of the women infection go unnoticed, even the chlamydia infection. So somebody might not even know that she got infection and it has blocked the tube. So this is one. Then another one is due to polycystic ovary, but this one is a bit easier because you give the hormonal therapy and induction of ovulation, and majority are able to achieve fertility. Now, recently, most of the young girls are getting what is called endometriosis. So, in endometriosis, where people feel painful cycles, most of the girls will come with a very painful cycles. That most of some of them might even need admission during their periods for management of pain. So endometriosis, what it causes adhesions. So when there are adhesions of the tube, now definitely that one you will not be able to conceive, because now the ovulation will be a problem. So movement of the egg is a problem. Definitely now we have issues there with fertility. Yeah. I think in brief, that is what is the common thing.
Thank you so much, Dr. Idioro. Yes, I think you've just mentioned many of the things that there's a concern with. Now, just to go back to you, the what you had noted about the issues with autism, especially detecting them when they're a bit early. As I said before, it's something that has been said to actually be there, and that's why it's important for mothers to, when they come to the pediatrician, to actually speak their concerns, because then it becomes a more objective assessment of whether the child is actually interacting with their environment. So if they notice what you're saying, that lack of eye contact, or this child not behaving like other babies, the babbling that they're supposed to do when they are 3 to 6 months of age, those the one what they're unable to have when they're 1 year of age, a smiling, what we call the social smile that develops between 6 to 10 weeks. Those are things that we check when we are looking at the under ones, and that's why it's important to always bring your baby for checkup after delivery. And we usually do assessments when they're 2 weeks. We do assessments when they're 6 weeks. We do assessments when they're 6 months, and then we do assessments when they're 1 year. And the importance of this assessment is to check every aspect of development, whether it's the emotional, the social, the physical in terms of movement, the speech. And this is able to give us an objective idea of whether this child is developing normally. And then we are able to make an adequate conclusion on whether there's an issue, even related to social interaction, depending on what the development of this child looks like. So if you have a concern, don't think that, oh, the doctor is going to laugh at me, or anything of that sort. just tell the clinician who's looking at your child, and it is their duty to assess and determine whether it's something that is of concern that needs to be looked into more carefully or followed up, or they can tell you, well, let's just wait and give the child time to get where they need to go. So thank you, Dr. Idioro, for that. And thank you for the short discussion about fertility. Now, another question that has come up, we are aware of some breaking news about something that has happened in Western Equatoria State, in a school called Iba Girls. And we have been informed that these children were given some praziquantel therapy. Praziquantel is a drug that's used to treat and also to prevent a certain parasitic infection called schistosomiasis. And as part of public health control, we sometimes give medications to the masses so that we're able to treat many people at once, and prevent either the development of complications or the establishment of disease. And this information that we've gotten has basically, what we've seen is a video where some of these children have what look like neuropsychiatric manifestations, and people are wondering what exactly is happening. So Dr. Idioro, do you have any thoughts on that before I give my thoughts? Yeah, just give us a bit, maybe a brief overview of what you think might be happening there. Unmute yourself, Dr. Idioro.
Okay, sorry. Now, what I can say is praziquantel is a safe drug. Usually those drugs are like the vaccine. They have been tried, and what has been noticed is that most of them, the side effects is very, very low. And what we say, the chances that you will get the side effects is really negligible, comparing it to the benefits that you will get out of this treatment. So I don't know, maybe we can associate it with the specific population where the drugs were given. We could reach a conclusion if, like, we have given the medication at the same time for like maybe people of the same age in most of the states in South Sudan. Then if all of them get, then we'll say there is a problem with the drug. But if it is only in a specific population, then we can, again, at the same time, look at it, the population, the genetic makeup of the population, and the risk that is involved with the medication. But since it is only in a minority of a population, like you say, they are only secondary school girls, Sama.
So
So if it,
the children who are given were in a secondary school for girls called Iba Girls, and a
yes,
few of them developed these manifestations.
yes, and they are all girls. So we will have to look into a bigger population to come up with a conclusive report for what exactly happened. Yeah, maybe you can add.
So yeah, thank you, Dr. Idioro. And I think what Dr. Idioro has mentioned is important, that it's important to remember that most of these drugs have been tried and tested in various populations, and they have been found to be safe and effective. But as with every treatment and every medication, there are always side effects. There are always side effects because each and every one of us have unique genetic makeups, and we respond to things differently. So if I take Panadol today, I might have a different reaction in terms of side effects as compared to Dr. Idioro, because our genetic makeups are not the same. So the way we process drugs, the way drugs act within us may be different, okay? So they might differ in very, very small variations because of our genetic makeup. And yes, side effects are expected for most drugs, even vaccines. However, the safety profile has been checked over the years. And when you try and balance between the public health impact in terms of prevention of disease and prevention of complications, specifically for praziquantel therapy, for mass chemotherapy that is supposed to be targeted towards this parasite called schistosomiasis. It's a parasite that has been known to cause bladder cancer. So just imagine the public health impact of eventually preventing cancer of the bladder versus not giving the medication and preventing the disease. So there will definitely be some side effects from certain medications and from certain vaccines, and a balance has to be found between whether the good outweighs what we'd consider probably in quotes the bad. So yes, praziquantel has been associated with some side effects, neuropsychiatric ones, where someone behaves abnormally and all that, and that has happened in certain populations, and it's something that's expected, but it's considered very rare. So as Dr. Idioro said, sometimes you have to look at it in terms of the bigger picture. Like when you think about epidemiology and research, you're looking at who is affected, where has this occurred, which region, among which people, among which specific population, what's the age group, what is the sex, and then you try and determine what factors about that particular region or that particular population or those particular individuals might be causing them to behave in a particular way towards a specific drug or a specific treatment or a specific vaccine. Of course, the hope is that with time, treatments and interventions can be targeted towards individuals, but it's very expensive to do that. So when the safety profile has been established in like more than 90% of the population, and the positive effects in terms of the public health impact are higher than when you think about the side effects that happens in a small part of the population, then you have to decide for the good of your public health, for the good of prevention of further complications that in this case can include bladder cancer. What would you rather do? So this is something that it's difficult to comment on until you're able to look at every aspect of what happened and the specific individuals who are affected. And of course, at this time, we hope that they're actually receiving the medical care that they require and that it's adequate. From the video, we can see a number of health professionals actually attending to them. And I think that is something that should be applauded. And we are actually on track in terms of helping out those girls who have been affected in that way. But I think more information needs to come out, and people have to look at all the factors that might have contributed to that. So thank you, Dr. Idioro, for contributing to that part of the discussion. Now,
maybe I can also add.
Yes, go ahead.
Yeah, like you said, there is no drug without a side effect. So actually, all drugs have side effects, but most of the drugs which are used have minimal side effects. Yeah.
Yes, and this is a question I get from quite a number of mothers. Some of my the patients for my mothers, when they ask about vaccines, when they ask about certain medications that we prescribe, and they ask about the side effects, and they ask about the long-term implications. I specifically do a lot of asthma care, and people are very jittery when you tell them about the use of inhalers. And there's this myth about children getting dependent on the inhalers and them developing like extreme side effects over time. And the explanation has to always be the same, that you ask yourself that if you're given a situation where you know that a certain medication is going to prevent progression to worse disease or prevent even death, what would you rather choose? Minimal side effects because the drug has actually gone through research and has been generally indicated to be safe, or you would rather deal with the consequences of progression of disease? And I mean, the decision is actually, well, I can't say it's straightforward, but when you look at the balance in terms of the impact on the health of that child, in terms of the subsequent issues related to even education, related to being out of school all the time because they're always sick, then the good then outweighs the bad. And it's always a balance. You have to do the balance, you have to do the math and decide that when I give this, then I'm preventing things further down the line that might have a worse impact than these side effects that have been noted with this specific drug or treatment. So this is how it works. You have to do a balance where you're not causing harm, but the greater good at the end of the day is achieved. Dr. Idioro, you have a comment on that?
No, not really.
Okay, fine. So the other question we're being asked is whether vaccines in South Sudan are safe. Dr. Idioro, do you have a comment for that one?
Which
And
vaccines
I know
specifically?
obstetricians don't deal with a lot of vaccinations, but there's some
Which vaccines
tetanus.
specifically?
Yes, they haven't
Or
they
just
haven't
any
they
vaccine?
have not they actually have not specified which vaccines they're talking about. Like a general question on whether vaccines are safe.
Yeah, I think vaccines are safe wherever they are. Uh, um, People consider vaccine in South Sudan are not safe, which is actually wrong. You know, vaccine is not only managed by the Ministry of Health in South Sudan. Vaccine is being managed by WHO and UNICEF and other non-governmental organizations. So there is no way someone will, the NGOs will bring in a vaccine which has expired. These are things which are at the world standard. And again, the cold chain in South Sudan is regularly checked, and it has to be confirmed that the cold chain is working, where the vaccines are stored. So the myths that vaccine in South Sudan are not safe, people think like since we don't have electricity all over South Sudan, that means the vaccines there are not well are not well stored, which is totally wrong. Our vaccines are very safe. Even during the time for when we were still at war, the vaccines were still very safe. Uh, I'm one of those people who have really taken all my tetanus vaccines in South Sudan. And my children, whenever the situation finds me in Juba, they are vaccinated there. I don't move with children for vaccination somewhere else unless the vaccine is not available in Juba. Like the time when we didn't have the hepatitis B vaccine in Juba, or the pneumococcal vaccine. That is what should make you to move for vaccine to another country. But otherwise, the vaccines in South Sudan are safe. Like even the COVID vaccine of recent, there was a vaccine which was because it was almost reaching the expiry date in South Sudan. So WHO has to intervene and take that vaccine, and was brought to Kenya, because at that time Kenya didn't have, most of the people who took the first dose didn't have the second dose. So those vaccines were brought from Juba to Nairobi, and I'm among those who took that vaccine. So because I know there is no way the COVID vaccine is actually a World Bank project. So there is no way they will want the vaccine to expire or not even stored well in Juba. This is money. The vaccine is very expensive, by the way. So there is no way people will neglect on the storage of vaccine. So I will tell anyone, the vaccine, especially the COVID vaccine, which is now ongoing, it is safe anywhere. It is the same vaccine, and the storage is the same. So if we can remember, in the beginning of the vaccines, people have to prepare their storage, and then the stores have to be checked whether they will be okay for storage of the same vaccine. So I don't think WHO will just take a vaccine to Juba when the plan is not yet in place. Yeah, so vaccine everywhere, even in South Sudan, the vaccine in South Sudan is safe. Yeah,
And
I've seen people traveling and people sending me messages. They want to come and take vaccine in Nairobi, and I tell them, myself, I took the vaccine that was brought from Juba. So all the all the vaccines are the same. So there is no compromise in the vaccine unless you just go at the back door to take the vaccine. But if you take the vaccine being given by the government, it is a safe vaccine. Yeah.
yeah, so Dr. Idioro is very right about that. The fact that multiple partners are involved when it comes to vaccination. I know UNICEF plays quite a very huge role when it comes to vaccines, especially in the pediatric population and generally. And we actually, there's a specific even specialty in medicine that's related to vaccine called vaccinology. And what Dr. Idioro has talked about, the cold chain, is about the way the vaccines are stored and transported and everything. And at every stage, there are always checks and balances to ensure that the temperature is right, the vaccine is stored correctly, the expiry is not the expiry date has not passed, and if there's any indication that the way the vaccine has been stored has been compromised, then there's actually a regular review, even in the places where they're stored, where these specific vaccines that have not met the criteria for safety are actually gotten rid of. Because of course, yeah, sometimes things fail. You don't have control over everything. The electricity might go off and you don't have a backup generator. Also, the protocols are that you cannot have a place where you store vaccines and you don't have backup in terms of electricity. You have to have. But if that happens, then there's systems where checking is actually done regularly, so that those vaccines that might have been affected by the storage or temperature are actually removed, and those that are expired are actually gotten rid of. So as long as the system works, as long as the cold chain is maintained in terms of storage and transport to the areas where the vaccines are needed, then those vaccines are safe. But as I said before, as we keep saying, me and Dr. Idioro, is that everything has side effects. There's nothing that doesn't have side effects. Even food has side effects. There are people who get allergy reactions to food. Okay, so as we said before, it's a balance. If the side effects are minimal, but the benefits to the population are great, then we go with either that medication or that vaccine, and they usually go through thorough testing and different stages of development where all these side effects and reactions are checked, and by the time they're approved for the public, then all these checks have been done. So don't be afraid to take a vaccine that has actually already been approved, because all those processes have been taken care of. And by the time it gets to you, then they have already been able to say that in terms of side effects, they're not severe enough to say that we will not give this vaccine. Because when we look at the positives, when we look at the kind of, in terms of disease, what we call morbidity, in terms of the way the disease affects you, in terms of mortality, when it comes to preventing death, then this vaccine should actually be given to the population. So for us, we will always be, personally, and I think also Dr. Idioro, from what she said, will always be pro-vaccination, because we have seen actually the impact and apparent. And apart from hand washing, they say it's one of the most effective public health interventions that has ever been discovered by humanity. And this is something that everyone needs to remember.
Yeah, let me just
Now,
add. Yeah,
yes.
like Anne has said, everything has a side effect. I always tell my clients,
Mhm.
all contraceptives have side effects, and not all contraceptives are 100%. Only one contraceptive that is 100% is abstinence. You don't have sex, you don't get pregnant. But all the other contraceptives, they have their failure rate, although very minimal, less than 0.1%, is still you can get pregnant. So
Mhm.
there is nothing that is 100%. Yeah.
Mhm. Thank you, Dr. Idioro, for that.
Yeah.
Okay,
And
so
there is
there's a
somebody's
question
just
about
going up. Yeah.
Down syndrome. Okay, so Down syndrome is, well, when we say something is a syndrome, we mean it's a combination of different things that when we identify them, we can place them in one box. That's the simplest way to say it. That's what we refer to as a syndrome. So Down syndrome is basically something that occurs before, as a baby is formed in the womb. What happens is that when the baby is being developed in the womb, we receive 23 pairs of what we call chromosomes from our mother's side, and the 23 pairs from the dad's side. Now, when this happens, then each and every one of us ends up with 46 pairs. However, when it comes to Down syndrome, there's a particular chromosome, what we call the chromosome 21, where the cell then receives 3 pairs of that chromosome instead of 2, either a full extra pair or a partial pair. And of course, there are many other different variations that are a bit too technical to go into. Now, what happens is that now when this happens in that forming child, then it directs the development of the baby in a specific way. In the sense that when you see a child who has Down syndrome or an individual with Down syndrome, then there are specific features that many of them have that are very, for people who have experience or who have been able to take care of such children, they're able to tell and look at the child and say there is a possibility that this child has Down syndrome. So they have specific facial features, and it also affects particular organs of the body. So the chromosomes are part of what directs the development in terms of how your body develops, how your organs develop. And therefore, if there's a little change and there's a little change or an abnormality, then it directs development in a specific way. And for most children with Down syndrome, you'll find that they have a specific facial features. So they have these eyes that are slit-like, and they have like the face, you can actually tell that this might be Down syndrome. There are certain features that you find on the hands. So I won't go into very technical explanation of that. However, what is of concern is that for most children who are born with Down syndrome, then we expect certain things. And that's why it's very important to identify these children when they are born, okay, so that you're able to intervene. So there are things that we anticipate and expect. One that's very important is that sometimes for most of them, they have what we call congenital heart defects, where there's a connection between the left heart and the right heart. So when they're born, we ensure that they're seen by a cardiologist who's able to look at the heart and see if there's a defect and how significant that defect is, and to determine whether they need treatment or follow-up. The other thing is that they eventually also appear to have issues with learning in terms of having short attention spans and slow learning. And therefore, these are children who will require special education. Some their hearing is affected, and they tend to have recurrent ear infections because of the way, in terms of the anatomy, the way we say the ear canal is built. Okay, so these are children who need follow-up by the ear, nose, and throat surgeons in case of that. And these recurrent infections can actually lead to hearing loss. And many have issues with vision. So these are children who need to be assessed their vision and might end up needing to use glasses like the ones I'm using right now because of that, to correct the vision. Some have cataracts where the eyes are hazy and they're unable to see, they're unable to see well. And for some, there has been an association with a type of blood cancer called leukemia. So when you do the routine or tests related to infections, then you're supposed to, as a doctor or a clinician, you're supposed to just look at the blood cells and ensure that that is not there. Then they sometimes have issues with the intestines, constipation, so they need follow-up by doctors who specialize in that specific area. For many of them, something else that concerns us a lot, even as pediatricians, is that they may have issues with the thyroid gland. The thyroid gland is a gland that's here. It produces a hormone called thyroxine, and this hormone is very important for growth. It's very important for metabolism. Metabolism is how you like break down things and utilize things in the body. And especially in the first few years of life, it's important, very important for brain development and for growth. So we check these children in terms of the hormone to ensure that they don't have a low low thyroid hormones, because if they do, then we need to supplement so they don't get the effects related to what we refer to as hypothyroidism. So a pediatrician can sort that out, but most of the times we refer them to specialists called endocrinologists, pediatric endocrinologists. Many of them tend to have obesity, and therefore, of course, nutrition has to be followed up, and quite a number of other complications. So, as I said before, many of the issues in pediatrics have to be followed up by it has to be multidisciplinary care. Like you can't, I can't say that as a pediatrician I'm going to, Dr. Idioro, you're on mute. Am I on mute? Okay, we can't say that as a pediatrician I'm going to just be the one sorting out this patient, because I know multiple things that might that this child might be affected by. So I have to send them to the right people. I have to ensure that they get education that is specialized. I have to ensure that they're seen by the ENT. I have to ensure that they're followed up by the pediatric endocrinologist. I have to ensure that the cardiologist has a look at them and ensures that they don't have any like heart lesion that's significant enough to require treatment, and they have to be followed up over time because of that. And then there are tests that we either repeat yearly or we do like over a span of maybe 2 or 3 years. And that follow-up is important. And the reason why it's important to be able to identify and diagnose it in the beginning is because intervention starts early and you know what to expect. And even as you speak to the parents, you're able to tell them that this is what usually happens when a child has this, and this is what you need to watch out for, and this is what we need to follow up. And I have come across parents who, at the beginning, there's a lot of denial, and I know this is something all of us have. If we're told we have any, like today, if I'm told I have a chronic illness, I am sure for the next 6 months I'll be in denial, even though I'm a medical professional, and I might not even take treatment. So denial is a real thing. And sometimes we even need to actually call in counselors to talk with these parents and to be able to prepare them for the journey. We have to introduce them to support groups so that they have people around them who also have children with a similar issue and have been able to walk the journey, so that they hold their hands, because it's a long journey. Anything that results in chronic, or anything that is a chronic illness or has consequences that span across a lifetime, it's a journey. So you have to get strength for it, and sometimes even it needs counseling and some support, even from support groups. So it's very difficult to even tell a parent that your child possibly has Down syndrome because of these features that we have found. And we sometimes insist on actually checking, doing studies, what we call chromosomal analysis, to confirm. Because once we confirm, then it's easier to now say, yes, this is what is going on and this is what we'll expect. And then you're able to tailor support for that particular child according to what you have found. So it's a very difficult diagnosis to give any parent, and it's very hard. Acceptance is very hard, but it is a manageable condition. And with follow-up, actually, many of these children are able to do things for themselves. Some of them, I've seen models who have Down syndrome. I've seen people who actually work in certain factories who have Down syndrome. So it's possible, when you intervene early and you give them the correct management and treatment, them to be able to have some ability or sense of self-sufficiency, where they're not completely wholly dependent on their or on their parents or their caregivers. So
Yeah,
yes, Dr. Idioro.
yeah. Let me just add on what you say. Actually, the Down syndrome is, like Anna said, is because of a chromosome, and there can be some sort of a mild Down syndrome depending on the abnormality of that specific chromosome. Yeah, so you can even find someone who is normal, but you look at him as like, or her as somebody who is normal, but he has the Down syndrome, which is the mild form, and they're just like everyone else. So like Anne has said, it depends on the chromosomal abnormalities that has happened. So early intervention is actually key. Now, somebody might ask, can we diagnose it early in utero when the baby is still in the womb? Can we diagnose Down syndrome? Yes, that one is a possibility, and most of the developed world they are doing. It's only us who are scared of the outcome that are not actually doing it, and again because we don't have our limited facilities. So it is usually said that Down syndrome is more common in the younger women, less than 25 years. The chances are like 1 in 1,000 or 1,400. And in ages more than 40 years now, there is the chances that when you are more than 40 years, the chances that you are getting a baby with Down syndrome is actually 1 in 100. So it's very, very, very high risk when you are more than 40 years. And now the first thing we usually do, we can check the ultrasound. By ultrasound, they check the what is called the neck translucency. They check the skin of the neck through the ultrasound. Then there is a specific measurements. Then they measure. If it is high, then that gives you a high chances of having a baby with a Down syndrome. Then when the ultrasound is positive, then we go to some blood tests are carried out, and we see the level of the hormones, which will tell us whether there is a high probability of a Down syndrome. Yeah, but most Down syndrome, since it is compatible with life, then the counseling actually starts early when the baby is still not yet born, so that the mother knows what they're expecting. And some of them will even be amazed when the baby comes out and with the mild Down syndrome, and the baby is very, very normal. Yeah, we can check for screen for Down syndrome in utero. Thank you.
Thank you so much for that addition, Dr. Idioro. Yes, that's very right, especially in the Western world where they have the capability to do it. They're able to, and also, well, ultrasounds and checking some of those signs that Dr. Idioro has mentioned, that is available to us. So it's something that we can actually look at. Now, maybe Dr. Idioro, we can go back to your field now. Let's talk about something that I think is close to your heart: screening for cervical cancer. Why is it important, and what is done, and what is the impact of it? Maybe you tell us that.
Yeah, I think we'll have to prepare for a day for cervical cancer, because like you said, it's something that is close to my heart, and actually that is what made me to go to doing this oncology thing. Yeah, so cervical cancer screening is actually because cervical cancer, we said, is one of the cancers that is preventable. You can prevent it because early screening usually leads to treatment. And we can get many patients who are cured of cervical cancer, and you are wondering, how can a cancer be cured? Because there are so many steps in treatment of cervical cancer. So I can say, if you go regularly for the screening and we notice abnormal cells, we advise you we rescreen after 6 months. Again, if we get at abnormal cells, there is something called colposcopy. We take a bigger biopsy. If that one comes abnormal cells, it depends also on the types of cells. We can do something called colposcopy. No, something called leap, whereby we cut a bigger part of the
Sorry, Dr. Idioro, sorry. I think Dr. Idioro we've lost Dr. Idioro there. We hope to get her back in a bit. So she was trying to basically give us a brief overview of how cervical cancer is diagnosed and how they take a part of the cells to be able to check them to ensure that there are no cancerous cells there. And it's, of course, it's very important for that to be done early, because when you're able to identify an issue earlier, then intervention first and foremost is not as in terms of intervention, then you're able to do things much earlier, and you prevent progression to like full blown very severe cancer that has now spread beyond a certain level when we're looking at the in terms of the depths of the cells that are affected. So I think when she comes back, then she'll go more into the technical details of that. For now, as I wait for her to come back, I'll talk a little bit about prematurity. Someone is asking about how you can take care of a premature baby at home. Okay, so well, when we talk about prematurity, when it comes to pediatrics, we usually consider a child as being preterm if they are born below, I would say, we can, or the cutoff is, oh, Dr. Idioro is back here.
Sorry, we are
Dr.
in
Idioro, are
Africa.
you hung?
Power
So
went off.
go ahead with the technical discussion about
I
the
have a
diagnosis of
blackout.
cervical.
Yeah,
Yes, please go ahead.
yeah. Uh, Now the screening that we are doing now currently is called a pap smear. And a pap smear, we take a direct sample. We take like with a brush, we take a direct sample from the cervix, and then we put on a slide. Then we send to the pathologist. Then they look at the cells which are there. But again, now we have the HPV testing, which is actually also part of the screening. So you can do HPV testing and pap smear at the same time. We call it a co-testing, so that in case both of them comes negative, we actually give you another like five years for testing again for cervical cancer screening. Yeah, so the screening tests are available. I think even in Juba we do the pap smear for now, and which is just a simple procedure. I think people are scared. First of all, people are scared because of the way the screening is done, because it is done through the vagina, whereby we put a speculum. But all these things have shown that it is not harmful, but actually it's just a discomfort. But now, if you put your discomfort against the chances of getting cervical cancer, so when it is actually something that can be done only once a year, why not doing it? And even if the screening comes negative with only the pap smear, we can repeat, and you don't have the risk factors for cervical cancer. We can repeat the test after every 3 years. So I think it's good just to go and do the screening once and bear the discomfort, other than going late and get you already have cervical cancer. Yeah, and cervical cancer is when you see people suffering with cervical cancer, it's really something which is it breaks one's heart, because you will say like, oh, this thing could have been prevented if she came early. Because even if you have a early stage cervical cancer and you're still a young lady and you want to have babies, still we do something called trachelectomy, whereby we remove most of the cervix. Then we leave you have you have your family size or the babies you want, but we don't give you much time. You can get the babies, then we go uh, for the definitive treatment. So actually, screening in cervical cancer is one of the best preventive thing. Yeah. Okay. Thanks.
Thank you so much, Dr. Idioro. We're going to dedicate a whole hour to cervical cancer very soon. So we'll inform you accordingly on when we will do that topic. So we're almost closing this session. And the last question, I have been told to talk about how mothers can care for premature babies at home. So I was trying to sort of come out, tell them what the definition in terms of when we talk about prematurity, what we mean. So when we're discussing prematurity, we talk about children who are born, babies who are born before 37 weeks, 37 weeks of the pregnancy. And the effects of prematurity depend on actually the age at which the child, the gestational age at which the child is born. So the closer you are to the delivery date, like towards 40 weeks, the 37 weekers, the 36 weekers, the 35, 34 weekers, the less the complications that are expected. The closer you are to like 28 weeks, 24 weeks, the higher the possibility of complications. So there are specific issues that are associated with preterms who are born at specific ages, and especially the ones who are born much, much earlier, they tend to have issues with their breathing, what we call respiratory distress syndrome, where they need to be put on the machines to breathe to breathe for them, and that can subsequently have impact on how the lungs are able to function later on. They might have issues with what we call retinopathy of prematurity, where their vision is affected. They might have issues with what we call intraventricular hemorrhage, where they bleed into the brain, and that might eventually cause features of cerebral palsy. They might even develop seizures, what we call convulsive disorders. So there's specific issues related to specific ages that these children are born that are special for a specific child. So of course, in terms of care, you have to think about that. Are there issues with breathing? Is this a child who needs oxygen when they're at home? Because the children who actually go home on oxygen, who are born much, much earlier, and they required support from the machines that we use in the NICU, the intensive care unit for babies. And there are children who, of course, will need follow-up by eye doctors because of the risk of retinopathy of prematurity. And there are those ones who will definitely need follow-up by the doctors who deal with brain issues and development, the neurodevelopmental physicians, and the neurologists. So those are specific, special issues depending on what age the child was born and what are some of the complications they developed over time. So what's important to think about when it comes to children who are born premature is, one, the fact that when you're born premature, you don't have enough what we call subcutaneous tissue, which is fat. Some of it is fat. So this really helps to keep the babies warm and all that. And keeping a baby who's premature warm is very important. So we encourage mothers to do kangaroo care for longer. Kangaroo care is basically skin to skin contact, where the mother's skin is exposed, the baby is placed right next to that, and then they're covered up. So that helps with bonding, and it also keeps the baby very warm. So in countries where they don't have incubators, there's a lot of kangaroo care that goes on, and that really has an impact in terms of mortality. It actually decreases mortality for this premature infant. The other thing that has to be focused on is nutrition. So because of the being born earlier and not being able to build up the fat and the stores that they need, these are children who are very prone to actually getting low levels of sugar in the blood. So feeding has to be quite consistent, and it has to be adequate. And usually for them, we prefer like 2-hourly feeds max. But of course, as they get bigger, then you go to 3-hourly and 4-hourly and all that. Then we want them to get a diet that is more substantial, in the sense that they require more calories compared to babies who are born term, so that we are able to actually build their bodies much, much better. So nutrition is something that has to be emphasized on. And of course, for all mothers, we do encourage breast milk. Breast milk is the best for all babies. For premature infants, sometimes we also need to supplement them with formulas that are a bit, in terms of calories, they're much, much better for them, that encourage their growth. So that one is on a case-to-case basis. Then the other thing that's an issue is that they have deficiencies of micronutrients, because towards the end of pregnancy, there's a lot of transfer of some of these nutrients. So the premature babies don't get that opportunity, especially if they're born 32, 34 weeks or below. So we tend to supplement folic acid, which is one of the supplements we give. We tend to supplement vitamin D, and we also tend to supplement calcium. And for some children, the supplementation of iron. So that is something that also needs to happen. And if your doctor gives you the supplements to give the baby, then you have to be consistent with the use because they are already born with a deficit. So for them, it has to be very serious in terms of consistency and commitment to giving those supplements. And the other thing is that we always have to, when we're looking at their growth and their development, we have to think about when they were born in terms of the gestational age, because there's a tendency to expect them to develop the way babies who are born term do. And that usually rarely happens. So you have to consider that this child was born like maybe 5 weeks before, 10 weeks before, and then monitor the development and the growth according to that. So it's you should not over expect in terms of their growth and their acquisition of what we refer to as milestones, which are the stages that a child has to have achieved by a certain age to be the same as children who are born term. So that's something to remember. Of course, vaccines are very important for these children because they're also quite prone to infections, and avoiding places that are crowded or people who are sick is very important for them because it's very easy for them to actually get infections, and that can bring them down because of their size, because of the complications that they have experienced. There has been a very high risk of what we call sudden infant death syndrome for them, where babies just pass on and you don't know why. So if this is a child who tends to have what we call apnea, they stop breathing for a few seconds and start breathing again. Those are children who most of the time are sent home on oxygen. It's important to be very, very, very in terms of attention to the child. For premature infants, it has to be very consistent because it's very easy for them to just either even have an episode where they're unable to breathe, and we lose a child because that was not prevented and it was not something that was concentrated upon. So, as in summary, these are children who need more attention. These are children who need warmth. They need good nutrition. They need micronutrients. They need vaccines, and they need follow-up to monitor their growth. And for those who have specific complications related to specific organ systems, then they need to follow up by the specific doctors or specialties that are involved with that. Okay, that's in a nutshell. So when it comes to the details, those are things that can be explained depending on or what that specific child, what issues that specific child has. So the earlier you are born, the higher the rate of complications, the more care that's needed. The later towards the pregnancy that baby is born, the more likely that everything will develop the same way as for infants who are born term. So especially for 34 weekers and above, we really expect them to do quite well. For the younger ones, it's a bit more difficult, but in places where there's appropriate care and adequate intervention that's done in a timely manner, then many preterm infants actually do quite well. And I've even commented for many mothers who come and tell me, oh, this baby was actually born preterm. And when it was, well, how many weeks of the baby? They say like 28 weeks or 30 weeks. And when you look at the child, you can't even tell now that this baby was born premature. So sometimes the kind of intervention and care that's given is what eventually determines how this child ends up at the end of the day. So for many children, if the intervention is appropriate and timely, especially if they don't develop very significant complications, then they're able to develop well. But of course, there are always issues associated with prematurity that we have to watch out for, and we have to intervene in case they come up. So that's in a nutshell. So Dr. Idioro, I think we should end this session. We've
Yeah.
done more than an hour, and I
Yes.
don't know if any
There
more
is just
questions
someone.
are coming in.
There is a
Yes.
question which has been posted about Clomid. Clomid is a prescribed drug, and I will encourage people to actually seek gynecologist's opinion and prescription, because actually these are drugs that we follow. We know we give 2-3 cycles. If it doesn't work, we add the dosage. If it doesn't work, we change to a different drug. So people should not get tired of walking into the gynecologist's office, because that is where we will get a better and good outcome of whatever we are looking for. Yeah, so over the counter self prescription, I totally discourage. Yeah, thank you.
Thank you so much for that, Dr. Idioro. In fact, if you found the pharmacists here, they'd be very, very unhappy about people self-prescribing certain medication. We have said this multiple times during this session, that every drug, every intervention has side effects. And the reason why many of us have to go to school and read all those things and have those dwelling sessions is so that we can understand and balance, you see. So for you to just walk into a pharmacy and get a prescription of a drug that has potential side effects, and maybe has what we call, there are particular drugs that are actually not given to specific individuals with specific conditions, um, who might react differently to that drug or accumulate that drug in the system. So it's important to actually seek medical advice before you use many of these medications, so that we can
Yeah,
prevent such things from happening. So this is
exactly.
something that I hope everyone takes as a take home, as one of our summaries of this discussion today. So,
Yes,
Dr.
and
Idioro, I will ask
to
you.
add
Yes.
into that, let me just
Mhm.
add, Clomid causes something called ovarian hyperstimulation, which is really a serious condition. So it's actually, that's why I will always advise we just follow up with a doctor. Yeah, you can go on. And
Thank you so much, Dr. Idioro. Actually, it's important to be very specific about a side effect, because when someone does not understand why you're
mm,
refusing or telling them no, then it's very difficult to actually follow those instructions. So I live by this rule of the thumb: explain, give the reasons, and then when someone understands what you're telling them, then they decide which way they want to go. But at least they have all the information. So you've all heard what Dr. Idioro has said. Uh, this hyperstimulation is actually a very, very serious thing, and you cannot just go walk into a pharmacy and buy uh, this drug just off the counter. It has to be prescribed by someone who has actually been given the rights to do that. Okay. So we will conclude our session today. As I said before, this is the first of its kind. So we thank you for those who have sent in questions. For those who haven't, then I think next time when we have a similar session, then we'd encourage you to just be free to ask your questions. If it's very difficult for you to ask it on the forum where everybody can see your name, then you can just inbox the South Sudanese Women Intellectuals Forum team or page directly on inbox, and then we'll be able to answer those questions and, of course, ensure anonymity. I know a lot of medical issues, of course, are associated with, some are associated with stigma, and there's need for confidentiality, and it's difficult to just ask questions openly where everybody can see who you are and your names. So you have the opportunity to actually inbox the South Sudanese Women Intellectuals Forum page. We have a button that requests you if you want to send a message, and you can just send your questions directly. And for those that we are able to answer, we will avail ourselves. And I think Dr. Idioro has actually said that she will have time to do that, and I myself will also do so. If you have any pediatric or child health related questions, or are not very satisfied with some of the answers we've given, whether in pediatrics or obstetrics and gynecology, please reach out to us on our South Sudanese Women Intellectuals Forum page on our inbox, and the admin will be able to inform us and will be able to reach out to you. So, Dr. Idioro, maybe you can give your concluding remarks as we end this session. Thank you.
yeah, thank you, Anne. It has been a nice session, and we encourage, if anyone has questions, please you just post them on the page, and we will be able to respond to them. And my take-home message to all women is checkup, and checkup. Regular checkup helps, whether you are still somebody who is still young and still giving birth. You walk into the gynecologist office and you will be advised on the necessary checkup which is consistent with your age. If you are actually our mothers, also you have a specific checkups that we will always be doing for you. So because regular checkups, I can't say now I'm okay, I can't go and see a doctor. It is good to see a doctor when you are okay, because most of our diseases show symptoms when they are already late. So it's actually always good to pick up these illnesses, or like cancers, so most of the time early enough, and we get better treatment. Like people always say the ovarian cancer is a silent killer. No, ovarian cancer is not a silent killer. If you walk into the gynecologist for a general checkup, you will be done an ultrasound. And if you are somebody who is postmenopausal, we will always pick the size of the ovary and say, no, this one is not normal. And we do some blood tests for you. And such things will be picked early. Cervical cancer, we have already spoken about it. And for the elderly, also again, we'll be able to pick endometrial cancer early, and we get a better treatment. So I will just encourage all of us to do routine checkup. I know it is expensive, but it is something which is done only once a year. I think you can actually save that money, that this one I'm saving for my next checkup, because a healthy mother makes a healthy nation. Because if you don't take care of yourself as a mother, you will not be able to take care of anyone else. So you will always make sure you make yourself happy and healthy before you make someone else happy. Thank you.
Thank you so much, Dr. Idioro. I know that as mothers, we tend to, and women generally, because we are nurturers and carers, we tend to put ourselves last, and therefore we don't focus on our small aches and pains. We just say, okay, that one will go away. We are more focused on, making sure that the home is working and the family is moving forward and all that. And we need to really learn that we are also important, and we are an integral part of our communities and our families and our nations. And when we are healthy, then our children are healthy, our families are healthy, our husbands are healthy, for those who are married, and we are able to actually take care of the people around us better when we take care of our health. And so, as Dr. Idioro has emphasized, checkup is very important. Now, for the mothers and their children, I would like to say that no complaint is an insignificant complaint. Sometimes you see things that us as health professionals are unable to pick up. And when you're concerned about something, please, please, please take your child to the clinic so that they can be assessed. There's nothing that should be looked down upon, because there are many things that have been missed uh, because mothers were not listened to, because they felt something was off, but they couldn't put a finger on it. And sitting around with a child who you think is unwell at home, or who you think is not behaving normally or developing normally, is not is something that I would like to discourage. So no matter how silly it is, or you think it is, just take that child to the hospital and let them be assessed, because there are many different things that can cause very non-specific signs, but someone who is trained and with a trained eye can say, okay, this is what is going on, and this is what we need to do for this child. So never be afraid or hold back in terms of taking your children from assessment, because this is something that's not, I can't say it's scientific, but I think that we as mothers generally, and as parents, we have been blessed with some sort of insight into when our children are behaving abnormally, because these are children we live with, so we're able to tell when something is off. And even if you can't put a finger on it, take those children to the hospital and let them be assessed. The other thing I want to encourage mothers is that please take your children for vaccinations. As I said before, it's the most important public health intervention that has been has been done, and it prevents a lot of illness. It prevents a lot of death, and you might not see it in that specific individuals, but for those who have done studies in populations, they have actually seen the impact in terms of reduction of disease and reduction of death. So it's important to take your children for vaccines. If you're not comfortable, have a discussion with a health professional, and they'll be able to take you through your fears and be able to demystify some of these myths that we carry around with us. And then you're able to make an informed decision and take care of misinformation, because there are many people out there who are purporting to actually be medical professionals or to have scientific knowledge, but they're speaking out of ignorance and fear. So by the time you're taking advice from someone, by the time you are putting into play something that you have been told to do, you have to have actually gone to a certified medical profession, whether it's in terms of maternal health, whether it's in terms of child health, or even general health. When we're talking about the men here, go to someone who has been certified to actually practice that specific specialty, or who has experience uh, in that specialty, to be able to tell you, yes, this is what I think it is, and this is what we should do. So getting information off the internet, off Google, off WhatsApp, might misdirect you in terms of what is going on with you, with your child, or with your family members. It's important to always seek medical care. And as health professionals, we have uh, been actually taken through rigorous training and been taught how to identify certain things. And therefore, it is our duty to assist you with whatever issue you come with. So don't be afraid. For the mothers, don't be afraid at all to go and even to ask questions, because information is power. So thank you, Dr. Idioro, for joining us today. Sorry, I went on a tirade. You know, when you get the opportunity to talk to people about health, you just get overexcited, and that is what I have done. So I will stop there. And I thank everyone in the audience for joining us today on the South Sudanese Women Intellectuals Forum. And I would like to thank the UN women who have always supported us with internet, although at the moment no one is in Juba, but we thank you for that support. We thank Aisha, who has been on technical support in the background, and we thank the audience for joining us. Please remember to join us for our next week discussion. We will put up the poster on Monday, and it's going to be a very exciting discussion. Please do not miss it. And for those who still have questions, remember you are able to contact us directly on Messenger on our page, and we are willing and available, myself and Dr. Idioro. And if we cannot answer your question, then we will recruit our colleagues who are also very willing to help you. So thank you so much for joining us, and we look forward to seeing you next time. Thank you, Dr. Idioro, and
Thank you
congratulations
all.
on
Thank
being
you.
the first
Thanks.
gynecological oncologist in South
Thank,
Sudan, and also
thank
being the
you.
first
Thank
female
you.
obstetrics and gynecologist in South Sudan. It's amazing, and you're an inspiration. Thank you so much, and thank you for coming
Thanks.
on our
Thank
discussion
you.
today. Thank you. Okay, bye
Thanks.
everyone, and see you next time.
Bye.